Dear students, it's a pleasure for me to present InSimu's case for such a large audience. I think the audience size is just optimal as we can hopefully discuss the case, and I would like to have active participation from the participants. So let's start with the case of Clive Blank, who has symptoms of back pain. The InSimu patient we chose for today is called Clyde Black, and we know that he was born in 1973, so he's 48 years old, and he's a male, and he has very simple symptoms, not very alarming, that he feels weak, and he has a pain in the flank that's in the back. So that's all we know about him. So let's start practicing. And on this screen, if you are not familiar with InSimu yet, you can find a very simple screen. In the right upper corner, you can anytime recall the chief complaints if you forgot, which is weakness and flank pain since 2 months. And in the lower part of the screen, there are two things: active, examine, and diagnose. So we won't jump to the diagnose right away because we have very little information about the patient, but we can start to examine him. Now, at this screen, you see you can start with history of the patient. And actually, this is a suggested way of doing the examinations. So history is just simply asking the patient to tell his symptoms and history, and then you can examine him physically. Well, a virtual patient you cannot really examine physically, but by the physical tests you will get results, and then you can move on the laboratory tests, and finally imaging and other tests. Now, it is advised to start with history and physical examination because at the end your patient examination will be scored according to how much time you spent on the diagnosis and how much money you spent on the diagnosis. And the history and the physical examination are usually simple tests which cost nothing and are pretty quick, and they orientate us already towards a diagnosis. So let's start with history. And here you see the list what you can order, and you can go through this list now, and you can suggest me what should we start with. So anyone who has an idea, just please tell me what should I click.
Let's start with the general patient parameters.
General complaints.
No, the general patient
general
parameters.
patient parameters. Okay. So we can see that this is a 48 years old male. Body height is 180 centimeters and body weight is 96 kilos. Not a lot of information. What do you think? What could we use from this?
We can also try to take the urinary history, because flank pain could be an alarming sign for kidney.
Yes, but I think we may be progressing a little bit fast with that. From here, you could...
What are the general patient complaints?
Okay, so at this point, I would just wanted to bring your attention to the body height and body weight, which is useful to calculate the body mass index, but actually you can see the body mass index at another part, which I forgot now, which is. Okay, so I think the general patient characteristics didn't bring us much closer to the diagnosis. So do you have any further suggestion from this sheet?
Did you check maybe his social history to see?
Social history is a good idea.
I'm sorry to ask, what are the general complaints of the patient?
General complaints. Here you can see body temperature. Well, actually, you can ask for these. So would you like to have any more information about any of these parameters?
We get the body temperature and sweating, pain,
sweating,
recent trauma,
and pain as well, to get more information on that.
Sweating is negative.
Okay. And also, could we order a urinary history? That was on the very first page.
Yeah, urinary history.
Negative, okay.
Can we check gastrointestinal history?
GI history. Yeah, I think these are good ideas because you are locating the pain and trying to figure out which organs are there. So in the GI history, we only see some further details about this flank pain, which started 2 months ago. It's recurrent, dull type on the right side, and the intensity is 6 out of 10. So it's intermediate intensity. And there is an important information that this pain is radiating towards the genital region. So does it narrow down our direction towards any organ system?
The reproductive system, the male reproductive system.
It could be a reproductive system or
The urinary system.
The
urinary
kidneys.
system. Very good. Okay. So is there anything else from the history we would like to see?
I think we should check the social history to check if he smokes or drinks.
Yeah, you already suggested social history, but we didn't do it. So the lifestyle is coffee 4 a day, non-smoker, alcohol occasionally, is divorced, has 2 children, 19 years old male and 17 years old male, and is a construction laborer. So actually, not much.
Can we check the male genital history?
Male genital history. The patient is sexually active.
Can we check past medical history first?
Past medical history is, I think, is generally a good idea. Similar complaints before.
Previous
negative.
hospitalization.
Past medical history, previous hospitalization, also negative.
Negative.
The other complaint was weakness. I think maybe we should ask about that in general complaints and weakness history.
Fatigue and weakness, yes. So actually, no new information, but the idea was good. It's generally advisable to check the details of the complaints of the patient.
What about the family history?
Family history, we tried already, but didn't do it, yeah. So this is interesting. The mother is 87 years old and is alive, but we see here, but you can see here at the bottom of mother cancer, and the mother had a kidney cancer, and it was diagnosed when she was 82 years old, and she is 5 years later alive. And the father died already, and everything's negative except diabetes mellitus. I think we did most the history. The left doesn't seem to be very relevant, so we can go to the physical examination. And what would you do first based on what we have from the history?
Check the vital parameters.
Vital signs. Vital signs is again something which is generally useful in most patients. The body temperature is in the reference range. Here you can see bold letters, the value of the patient and the reference range below. And then the heart rate is also in reference range. Oxygen saturation is close to 100%. Respiratory rate, reference range. Capillary refill time is 1. And the blood pressure seems to be a little bit low. Okay.
Can we do an abdominal physical and a male
Abdominal
genital
physical, I think, is the best choice at this point. So skin is normal, distension is not present, external masses are not visible, bowel sounds are normal. With percussion, both liver and spleen are normal. With palpation, no resistance is present. There is some pressure sensitivity in the right lumbar region. So that's where the pain is. It's also a little bit pressure sensitive, and abdominal guarding is not present. Costovertebral angle tenderness is not present, and hernias are not present.
Can we examine the patient's general appearance?
Yes. What we see here is that the patient is consciousness is alert, is in poor general status, is overweight, but otherwise everything's normal. So in this case, the general appearance didn't tell us much. Anything else from the physical examination?
We do a male genital physical.
Yeah, because of the radiation of the pain, we can check the genitals, and regarding the penis, everything's normal. Regarding the testes, everything's normal.
Can we check cardiovascular because he's slightly hypotensive? So can we also check cardiovascular if everything is normal or something?
Cardiovascular, everything's normal. So the hypotension, if it's significant, it may not be originating from the heart. I think we did most of the history and physical. Extremities, musculoskeletal, skin doesn't seem to be relevant, so I would skip those. And then we can go to the laboratory. So which lab test would you order? What are the diagnosis you are thinking of at present? The ultrasound is imaging, so that's the next step. So maybe some laboratory could be helpful.
Could we do a
blood count?
Complete blood count.
We had the same idea.
I was also saying the same thing.
We can start as any patient general parameters. We can start with a CBC.
So here is the complete blood count.
Urinalysis.
The complete blood count is negative.
Urinalysis.
Well, if the complete blood count is negative, we can still go for complete blood count with differential. That may be somewhat more informative, but actually we don't see much except pretty significant monocytosis. Yeah, I think the urinary is a good choice. I would also go for urine analysis. However, you have here a lot of tests. So at the beginning, there is the rapid urine test. And I think that's a good choice generally, because unless you have a very specific diagnostic idea, the rapid test is cheap and fast and may give you some orientation. And you see here normal pH, negative for most parameters, actually for all of them. So actually the urine test is negative. So it's still a difficult case.
We can still go for the glomerular filtration rate to assess the kidney's function.
There is a slight elevation of blood urea nitrogen. Urine basic panel is still negative. So do you have any further ideas about laboratory tests?
Can you check the creatine level? Because you just checked the BUN creatine ratio, but you didn't check the creatine ratio from urinalysis. The creatine level.
From, yeah, I think the serum tests.
And the total.
Serum creatinine. Serum creatinine is in reference range.
I think maybe we should move on to an abdominal ultrasound, because
I think so too. So we can go now to imaging, and this is the list of possible imaging tests. So which one would you go for and why? You suggested ultrasound. Why?
It's cheap and
faster, cheaper, and safer.
Yes. Yes, for a general orientation in the abdomen, ultrasound is the first choice. And of course, we don't want to do the head and neck ultrasound and not the chest, so abdominal ultrasound. And here you can...
On the kidney and the ureter.
We can just click all because they all cost the same.
Yeah, that's what I wanted to suggest, that although you can save some time, since we still don't have a very strict diagnosis, or theoretical or hypothetical diagnosis, we can go for the complete abdominal ultrasound. And however, which one would you check first? Although there is the impression at the bottom and the top, so this at the bottom, so that's very helpful. You don't have to go through all the screen, because at the bottom there is the summary, the opinion of the ultrasound doctor or the ultrasound specialist, and it says that it's a right focal renal lesion with possible central necrosis, and the appearance is predominantly malignant.
With the family positive history.
Sorry?
He has a positive family history of renal cancer with
Very good point. Very good point. Yes. Okay. So actually, that's a pretty good. That brings us much closer to the diagnosis right now. Would you do any further tests?
Yes, you can do biopsy.
Biopsy.
Can we see the details on kidney for the ultrasound?
We already have the abdominal ultrasound, so we cannot request it again once more. But that's a very good idea to see the details about the kidney. So the left kidney is 9 centimeters. It's echogenicity is regular and the parenchyma is normal, whereas in the right kidney, it's 2 centimeters bigger. It has a hypoechoic mass visible in the parenchyma, and the details of this mass is that it looks heterogeneous with hypoechoic anechoic components. It's about 8 centimeters in diameter, which is very important, as you will see later. And regarding the blood vessels, luckily, none of them is involved, and the sinus is not involved. The renal capsule is not visible. You will see later that it's important for renal cancer staging if the capsule is involved or not. So it was a very good idea to check the details. We see that this renal mass is about 8 centimeters at its largest diameter, and the inhomogeneity is suggestive of malignancy, and also by ultrasound, benign renal malformations are usually cysts, and cysts are echo-dense. Okay, so we know now quite much about the origin of this flank pain. And would you like to do any further investigation?
We can see the CRP levels. They are mostly increased in malignancies.
That's
the
true.
C-reactive proteins.
But not in this case.
Can do a renal biopsy.
Since the ultrasound suggested that it might be malignant, won't it be advised not to do a biopsy because it could spread by seeding through the renal capsule?
Yeah, what you're saying is correct, definitely. But you also want to know the particular type of tumor that you're dealing with in order to know a precise management. So I think an ultrasound-guided biopsy can be of help in this patient.
I'm really happy about this discussion, and this brings us to a very important point. Should we do a biopsy in a renal cancer patient or suspected renal cancer patient or not? And the guidelines say that if the tumor is smaller than 7 centimeters in diameter, that is stage 1 kidney cancer. And that is, in that case, sometimes biopsy could be performed according to newer research because they can be sometimes benign. However, the therapy in most cases is surgical removal of the tumor as soon as possible before the tumor spreads. And there are several arguments against biopsying a tumor which is bigger than 7 centimeters. The guidelines say that it should be removed, okay? So, however, I do suggest that we check the biopsy because we will know even more about this disease, renal biopsy image guided, and it says that it's a clear cell renal cell carcinoma. So actually, we do have a diagnosis now, so we can go for the diagnosis, and it's the ICD.
Shouldn't we do a staging before to see if he has a lymph node or other metastasis?
We could do an abdominal CT for further staging, I think.
Or we could do a PET CT scan.
We can order a PET CT scan, but I think it was clear because there is the capsule still intact, the blood vessel still intact, so there is no angiogenesis or anything. So I think it's still in the first stages of renal cell carcinoma.
That's right. And if there were some findings, we would have had it on the ultrasound.
So I think Aslam's comment was very great on the point that the good thing about renal cancer is that it usually metastatizes quite late. And as long as the capsule is intact and the blood vessels are not involved, the systemic spreading is not very likely. However, we can go for these. And the PET-CT says that from the vortex of the skull to the distal toes, the impression is a focal lesion in the right kidney, and further imaging is required. So actually, we could go for the details if you want, but generally, I think the PET-CT is negative, and it could be repeated later, especially if some markers would be positive for renal cancer. Renal cancer can have paraneoplastic syndromes in 20-30% of the cases. So if paraneoplastic signs are present or appear later, that would be suggestive of systemic spreading of the disease. Mate, you suggested something?
Yeah, I suggested the staging, CT for staging, but we did that. So
yeah, actually for the staging, first stage is below 7 centimeters, second stage is above 7 centimeters, and then third stage is if the cancer has already entered any blood vessel or spread through the renal capsule, and fourth stage is if we see lymph nodes or other distant sites. So actually the PET-CT would be probably the most straightforward and better. Okay, so any more suggestions regarding diagnostic procedures?
I think we have our diagnosis.
Yeah, actually the biopsy was very useful. So we look for malignancy.
Can check for a malignant neoplasm of the kidney.
Yeah, malignant neoplasm of kidney except renal pelvis is C64, and then we have 64.1 and 2 for the right or the left kidney. So this was the right kidney, right?
Yes, sir, the right kidney.
And indeed, the diagnosis is correct. So here you can see the tests which we performed, and on the right you can see InSimu's evaluation whether the performed test was correct, and it's in the line of the evaluation process which the algorithm. You can see that most of the tests we have chosen were got a green point saying that that's part of the suggested algorithm to investigate a patient. We can see some orange points which say that, which mean that it's an alternative way of investigating. It's not in the optimal diagnostic pathway, but it does do no harm to the patient, but it may increase the costs. As you can see in the upper panel, the optimal spending would have been $360 and 5 hours and 50 minutes. And we spent $2,700, so almost 10 times as much as necessary, and 82 hours, which is again much more than 5 hours, 20 times more. So we can improve on this. And it says that general appearance was not necessary. The complete blood count was not necessary because we did the differential. So actually, in this case, the differential may have been better than just doing the complete. Abdominal ultrasound is suggested not optimal, although I think ultrasound is the first choice, but probably the orange dot by the ultrasound is because we could have done the CT. Here you can see the missed tests, and we didn't go for details on the pain. Appetite and weight change are negative, as suggested on the right side. We didn't do the comprehensive metabolic panel, which is actually negative in this patient, but in some patients who have paraneoplastic syndromes, the comprehensive metabolic panel may be positive. And the sedimentation rate, we did want to test. Someone suggested, but maybe we didn't go for it. So I think that shouldn't be considered as
I think there's a red point on the renal biopsy.
And there is one red point about renal biopsy, which the red point suggests that it's harmful. So according to presently available guidelines, if the imaging is quite positive for cancer, then the biopsy is contraindicated because, as you mentioned, injuring the renal capsule can lead to potential spreading of the disease. And even only a few cells, if they get into the bloodstream, they can be a source of relapse. So I think that's more or less the first part of this demonstration. I would like to ask you if you have any further questions. If not, then we can move to the second part. Okay, so how common is renal cancer? Actually, it is thought to be quite seldom, but it is about 5% of man cancer and 3% of cancers in women all around the world. And thus it's about the seventh most common cancer in men and the 10th most common cancer in women. You can see on this picture that it's more common in males, about twice as common as in females. And interestingly, it's much more common in the developed version or areas of the world, and it's much less common in underdeveloped countries. The overall 5-year survival is about 75% altogether for renal cancer cases, and this is a surprisingly high survival, especially if we take into consideration that renal cancer is a hidden cancer. As we have seen, it doesn't give a lot of symptoms, but it is often found incidentally by doing imaging of the abdomen for other reasons. So most commonly, renal cancer is an incidental diagnosis. We have seen some of the symptoms which can trigger diagnosis. So pathologically, we have seen the clear cell carcinoma, which is actually 90-95% of all renal cancer cases. It's the most common form, and it's called clear cell cancer because the cells have this unstained nature in the hematoxylinosin staining in the micrograph. Further types, macroscopically, we see a nest-like arrangement of the cancer cells. Actually, clear cell cancer can appear also in other organs like the uterus, the ovarium, or the colon. And altogether, the clear cell cancer incidence is somewhat higher. It's about 5 to 10%, including these other locations. So the second form which can be pathologically present in the kidney is the transitional cancer or urothelial cancer, which is actually 95% of the bladder cancer cases. So it's the most common bladder cancer type, but seldomly it can also appear in the urothelium of the upper urinary tract. So you can see that the urethral is the source of this kind of cancer. And the third type is the Wilms tumor or nephroblastoma, which is present mostly in children. So these are the most common types of renal cancer. Just for pathologic correctness, there are further subtypes of renal cancer summarized here. I won't go into details as we can leave this part to pathologists and specialists, as in most cases, there is no therapeutic relevance. Actually, that's one reason why a renal mass bigger than 7 centimeters won't be biopsied generally. On the contrary to other cancers, is that actually, as long as it is localized to the kidney, removal of the kidney or removal of the tumor is the therapy, and the actual exact cell type is not so important. Here you can see benign types as well, but benign renal tumors grow very slowly, and they seldom reach a size over 7 centimeters. But still, according to recent research, a biopsy could be performed in the case of small tumors. So there are some differential diagnostic questions, but in the case of renal tumors with different pathology like sarcomas, carcinoids, or the mentioned benign tumors, the therapeutic consequence is not so important as long as the tumor is confined to the kidney. However, it is important to know if the renal mass is part of another systemic disease, such as metastasis or lymphoma, both from a different diagnostic as well as from the therapeutic point of view. From the risk factors of renal cancer, you can see here an age-related appearance. So this is the average number of new cases per year and the age at diagnosis. And you can see a small peak here for Wilms tumor because the nephroblastoma is actually a genetic cancer appearing in newborns and young children. And then actually renal cancer is very rare before the age of 40. And there is a peak between age of 60 and 70. And also on this curve, you can see that it's about twice as common in males than in females. Smoking is the most established risk factor for renal cancer. Although in the case of Clyde Black, in the lifestyle attributes, we saw that he was not a smoker. Still, about every third renal cancer patient is a smoker, and the relative risk shown here increases 1.5% almost in the case of people who ever smoked. Also, for body weight, there is a linear correlation between body weight and renal cancer risk. And diseases involving the kidney also elevate the risk of renal cancer, such as high blood pressure or renal failure with long-term dialysis, or non-steroid anti-inflammatory drugs, which can also induce hypoxia of the kidney and renal disease. There are some inherited syndromes which also can increase the risk of renal cancer. And the von Hippel-Lindau gene, for example, is mutated in about 20% of the renal cancer patients. I included some sources if you're interested to read further. The family history we have seen also in the case of Clyde Black is important because it's also an important risk factor that patients with family history of renal cancer have renal cancer more often. And of course, bladder cancer is also a risk. Actually, renal cancer, as I mentioned, is usually doesn't cause symptoms. The most typical symptoms are blood in the urine. Generally, tumors tend to bleed all over the body, and blood in the sputum is alarming for lung cancer. Blood in the stool is alarming for colon cancer, and blood in the urine is alarming for renal or bladder cancer. Feeling of a mass or a lump in the back or pain that doesn't go away are also typical symptoms of renal cancer. However, this typical clinical triad appears in less than 15 or 10% of renal cancer patients, and usually only in advanced cancer. There are some further possible local symptoms, also usually by advanced cancer. When the cancer enters the renal vein, it can cause occlusion there and induce venous stasis in the lower part of the body, such as the testes or the legs, and can cause varicocele or leg swelling. Or swelling of the ankles, but that is more a consequence of reduced renal function. Also, by advanced cancer, as you can learn in many other types of cancer, there are general signs of tumor burden. When the tumors grow big, they have some symptoms involving the general well-being of the patient. Appetite is lost, the tumor consumes a lot of energy, and together with the appetite loss that leads to weight loss, the patient becomes tired. Fever can develop. In the case of several cancers due to superficial bleeding, chronic bleeding, iron deficiency anemia may develop, and night sweats are also typical for advanced stage cancer. And of course, the metastasis can have signs or symptoms. Renal cancer primarily metastasizes to the lung, so shortness of breath, coughing up blood, or continuous cough could be signs, or by the case of bone metastasis, bone pain, or pathologic breakage of the bone, and also by lymphatic metastasis, palpable lymph nodes can be diagnostic. We have tried the blood and the urine tests, and they were negative in our case. In the blood, you can see anemia, for example, or also polyglobulia, because the renal cancer can, on the one hand, destroy most of the kidney and thus destroy erythropoietin production, but also as a paraneoplastic syndrome, the renal cancer can produce erythropoietin, so both anemia or erythrocytosis can be signs of renal cancer. As I said, about 20% of renal cancers have paraneoplastic syndromes. That means the paraneoplastic syndromes we can group into hormonal and non-hormonal forms. And here are some examples, what kinds of hormones can be produced by renal cancer and what can be the consequence of it. So parathormone-related peptide leads to bone breakdown, elevation of serum calcium and hypercalcemia with calcifications outside of the bones in the body, and also elevated alkaline phosphatase levels in the blood. Erythropoietin production can lead to erythrocytosis, renin production to high blood pressure, prolactin production to galactorea, that is producing of milk of the breast, even in the case of males, and glucagon can be produced, which can lead to impaired glucose tolerance and diabetes. Regarding the imaging, we have started to discuss that ultrasound is usually the first imaging and enables to distinguish between benign kidney cysts and tumor masses. So the ultrasound is mainly differentiates between fluid and solid masses. And then the CT is actually the best choice in the case of renal cancer because it can verify the diagnosis. It gives information about the contralateral kidney, its morphology and function. So we know if we remove the tumorous kidney, what kind of kidney function can we expect. And it is important for the staging because we can see the tumor extension, we can see if it enters the blood vessels, if it infiltrates the lymph nodes, or is there any extrarenal spreading. And the MRI is actually a substitute for the CT. It is done only if venous involvement is suspected, and therefore the CT may be, the contrast material may not reach the kidney, or if there is a proven allergy to intravenous contrast materials, then the MR can substitute the CT. And finally, the biopsy, which we already discussed more or less. So imaging is usually sufficient to differentiate benign and malignant masses. And the surgical management is removal of the tumor independent of the histology. However, for small renal masses smaller than 4 centimeters in diameter, the biopsy can be considered. As about 20% of the small renal masses smaller than 4 centimeters can be benign. This is the staging. So we already discussed this. Stage 1 is when the tumor is smaller than 7 centimeters in diameter. Stage 2 is when the tumor is bigger than 7 centimeters in diameter, but still confined to the kidney. And stage 3 is when there is some local spreading. So the renal fascia is not broken, but spreading into the renal vein is possible, and also lymph nodes may be involved. And stage 4 is when there is a breakthrough of the renal capsule, and or there are distant metastases. And as we discussed, lungs and bones are the primary sites of renal cancer metastasis. So this shows the survival, and actually at stage 1, the survival is around 95%, and also in stage 2, 88%. However, at stage 3, the survival drops to 60%, and at stage 4 to 20%. It's not part of this lecture, but recently there are improvements and new avenues of cancer therapy in general, which can increase this low survival in the future. So the prognosis is, as the disease is presented usually at an early operable stage, about 60% of the renal cancer patients are discovered at stage 1, and a further 10% is discovered at stage 2. So about 2/3 of the patients are discovered early, and therefore the prognosis is pretty good. As long as the small tumors are confined to the kidney and there are no symptoms and the diagnosis is accidental, the prognosis is good. Also because, as I said, renal cancer gives usually metastasis at late stages, not unlike, for example, melanoma or small cell lung cancer, which give metastasis at a very early stage. About 30% of the cases are discovered at stage 3, and there is a risk stratification, and the Memorial Sloan Kettering Cancer Center risk stratification is used most of the cases in the clinics, and still in stage 3, about 45% of the cases have a favorable prognosis, and only 3% has a poor prognosis. However, in significantly advanced disease, the prognosis is usually poor. You can see here a timeline from 92 till 2018, and you can see that in the US, kidney cancer becomes more and more common. However, the mortality is somewhat decreasing. And finally, as InSimu doesn't yet have a therapeutic part, I would just very briefly mention the general principles of tumor therapy, and this may be the take-home message, that as long as the disease is local, the therapy is surgery, and even nowadays we consider a tumor treatable if we can remove it. And if the disease becomes systemic, that means distant metastasis, hematologic metastasis, then the disease needs systemic therapy. That means chemotherapy, radiotherapy, immune therapy, or targeted therapy. Do you have any questions?
Okay, I wish to ask if the alkaline phosphatase is a measure of renal osteodystrophy.
Well, actually, alkaline phosphatase is an enzyme which is normally found within cells and in low amounts in the blood. And if it's elevated in the blood, it's suggestive of cell destruction of the cells which have alkaline phosphatase intracellularly. And these cells are mainly bone cells and liver cells. So alkaline phosphatase elevation is suggestive of bone destruction or liver problems.
Okay, thank you.
There are some other more seldom causes, but these are the most important ones. Thank you for your attention and intense participation and active collaboration. You will have a homework assigned to you per email. You will also get the homework patients on your phone, and you will have 2 days to evaluate them. And then in the next session, we will discuss your questions. Thank you again.